Welcome to the Pediatric HIV update from CROI. My name is Dr. Allison Ross-Eckerd. I'm from Emory University in Atlanta, Georgia, in Children's Healthcare of Atlanta. I have two colleagues here. One is, why don't you go ahead and introduce yourself?
So I am Dr. Sarah Fargo, instructor of pediatric in the Department of Pediatric Infectious Disease at Case Western Reserve University and Rainbow Babies Children's Hospital.
And I'm Dr. Ann Sharuti from Emory University, as well as Children's Healthcare of Atlanta. I'm an assistant professor there.
So there were some very interesting abstracts that were presented at CROI this year in pediatrics. We had identified a number of themes that we thought were quite relevant to discuss. One of the big topics, which I'm sure all of you are aware of, is the update on the Mississippi baby who presumably looks like she may have cured her HIV by early antiretroviral therapy. Now, we're not going to be talking about that today. That's going to be covered in another session. But what we would like to talk about is a theme that was covered quite extensively, which was early antiretroviral therapy initiation in HIV-infected infants, some of the implications of that, both good and bad. So I'm going to turn to Dr. Sharuti. There were a couple oral abstracts that were presented and posters as well, looking at the virologic and immunological implications of starting ART soon after birth.
Right, I wanted to bring up one oral abstract that was presented by Dr. Debbie Prasad from Johns Hopkins, where they used the FACS cohort to examine viral reservoirs in pediatric patients who were treated with antiretroviral therapy from a very early age. They looked at three different subsets of patients. The first were treated and virologically suppressed at less than 1 year of age. The second was treated and virologically suppressed between 1 and 5 years of age. And then the third was started on therapy at greater than 5 years of age. And they defined virologic suppression as two viral load measurements less than 400 within a few months of starting antiretroviral therapy. And they had to maintain that viral load of less than 400 up until the time of testing. Now, they did allow for a few viral blips, and about 25%, I believe, of the patients did have detectable viremia at some point along their course. And the testing that they did was actually, the patients had been on antiretroviral therapy for a median of 10 years. So this was quite long after antiretroviral therapy initiation. They were a median of 14 years old at the time. But the main finding of this study was that the patients who achieved virologic suppression at less than 1 year of age had significantly lower levels of proviral DNA in their peripheral blood mononuclear cells, so lower viral reservoirs. And this was quite striking, comparing the patients who were started on therapy and suppressed at less than 1 year of age compared to those who were started on therapy at a later time point. And this clear benefit of early antiretroviral therapy in perinatal infection shows that we potentially can have an impact on proviral reservoirs in the blood. There were some caveats to this story. They did not study sorted CD4 T cells, for example, or different memory subpopulations, and of course they were only able to look in the peripheral blood and not in tissues. But it was quite striking, and the first study of its kind.
So that kind of leads into the idea of, if you treat them very early and decrease the reservoirs, could you in fact create a patient who can potentially come off therapy at some point or has longer virologic control, better immunologic control. And there was a study that actually discussed that, if you want to
Sure.
talk about it.
The group of Louise Kuhn presented data on virologic dynamics by age of ART initiation. And so they were primarily looking at the ability to suppress viremia depending on when the antiretroviral therapy was started. And so they had 3 different cohorts from South Africa, and they compared patients who were started on therapy at less than 6 months of age to those who were started on therapy between 6 to 24 months of age. And they were able to show that the patients who started on therapy at less than 6 months of age were less likely to fail their regimens by 52 weeks post-randomization. They were also less likely to have virologic blips of greater than 50 copies per ml in the blood than the patients who had started on therapy at 6 to 24 months. And overall, I believe this was in the third cohort, they showed that children who started therapy at less than 6 months were more likely to suppress their viral load to less than 1,000 by 6 months after initiation than those who started later. So overall, this showed there was a greater virologic control in patients who initiated therapy at an earlier time point. And this is not, it should be noted, sort of very early therapy, i.e. within the first hours to days of life, but it's comparing sort of a more realistic initiation of therapy in the developing world.
So this was a common theme throughout CROI, when to start, what to start, and the implications of that. So in this particular study, they looked at children who were less than 6 months old starting, and that brings up a lot of issues regarding how to identify these patients, keeping them in care, and a lot of that ties into option B+. And I thought maybe you could talk a little bit about that and some of the implications.
Just kind of a recap, option B+, let's talk back and go back to 2010. So W.H.O, new W.H.O guidelines came out in 2010 for women who at the time were not eligible to start antiretroviral therapy. So if their CD4s were not less than 350, and if they were not in WHO stage 3 or 4, at the time they were not eligible to start antiretroviral therapy. So the World Health Organization came out with two options for, mainly what I'm talking about is resource-limited settings. So countries could either pick option A, which was starting women on AZT at 14 weeks of gestation and giving them single-dose nevirapine and then a 3TC tail, and also single-dose nevirapine to the infant for 6 weeks of age. Or option B, which was starting triple therapy in the second trimester and also through birth and continuing the single-dose nevirapine to infants through the breastfeeding period. That being said, both of the options meant that women had eventually to start antiretroviral therapy either at birth or right after breastfeeding. And Malawi was very kind of aggressive and realized that they did not have the capacity to do CD4 testing. And they also realized that there was a high fertility rate. So on average in Malawi, women have 5 to 6 children in their lifetime and breastfeed on average for a period of 24 months. So that meant a lot of stop and start. And they were the first country in 2011 in the third quarter to go with option B+, which was putting all women who were pregnant on triple therapy and continuing them on therapy for life. And so what we've learned at this meeting, now that it's been since 2011, we have a little bit more data, is that we've had a great uptake in these settings in rural areas that did not have the capacity to do either CD4 or viral load. Greater than 700-fold increase in moms who are put on antiretroviral therapy, which is great, but also what we've learned is that PMTCT doesn't mean just putting moms on treatment. It also means following them through the breastfeeding period, making sure that infants are tested, so early infant diagnosis, and linked to care through breastfeeding. So there are a couple of good abstracts from Malawi and Uganda, these countries that were very aggressive in starting option B+. What we saw is that it's great in theory, but we have 20% of these women are lost to follow-up after 6 months. We see that less than 40% of the infants are linked up into care. So that means within that 6-week period, moms are taking the treatment, but we're losing the baby, so we're not really testing them. On a positive note, what we saw from the Baylor group in Malawi and also from the Elizabeth Glaser Foundation in Uganda is that we have lower rate of transmission from these moms that are on option B+. So just to give you some numbers, before option B+, the rates of MTCT in very good control setting was about 4%. After after a year of option B plus, we saw rates declining to 2%. And in Uganda, these numbers were 9% down to 5%. So these are all great numbers. But just to kind of wrap it up on option B plus, I think some of the things that we've learned at this meeting was that we need better testing. So again, if we have stockouts and we can't test these moms, what's the point of doing option B plus, which is some new kind of research coming out of Northwestern, doing kind of point of care testing, rapid testing in the field in resource limited areas. And then the kind of second thing that we have to keep in mind is retention in care, how to keep these moms in care long term.
So of course, our ultimate goal always is to prevent mother-to-child transmission, and that's the point of the option B plus, not only improving the maternal health for her lifetime as she ages, but also in the infants. And it's always a balance of risks and benefits, because obviously that means that these infants will be exposed to antiretrovirals for a much longer period of time than they would be in utero, as well as if you start them early, as we talked about previously. So obviously we want to prevent the mother-to-child transmission, and in those babies, they are HIV exposed but uninfected, and they've been exposed to in utero as well as postnatally antiretroviral therapy. And of course, our goal is always to do no harm. So there have been people looking at that as well. If, of course, preventing HIV is far outweighs the risks of long-term exposure, but it is something to think about. There were a number of abstracts at CROI looking at in utero exposure, both in exposed babies that turned out to be uninfected as well as infected babies. And of course, there were some studies that showed that it was a good thing. Some studies showed that it was a bad thing. But I wanted to point out a couple abstracts that I thought were worth mentioning. There was one study where they looked at mothers who started combination antiretroviral therapy before or after 24 weeks of gestation. And in those babies, sorry, losing track here a little bit. There was a decreased rate of preterm labor in those that had started earlier, which goes again towards starting earlier. There was also another study that showed that better virologic control in mothers throughout their pregnancy, and with a greater CD4 count, that those babies had a increased weight for age and length for age. So there is something to be said for starting early, as you would with option B plus with the subsequent deliveries. But there was also one concerning abstract that was presented by Dr. Siberi from NIH, who looked at antiretroviral exposure, particularly Tenofovir, which, as you know, is one of the NRTIs that we use much more commonly now. It's the first-line regimen, and so as women become pregnant, more and more women we're finding are going to be on Tenofovir.
And just to pause here for a second, that's also what's being used in option B plus. So we're giving these mom Atripla, which is 3TC, Tenofovir, and efavirenz. So it's, this is an important study not only here in the United States, but also as we're being more aggressive in putting all these mothers on treatment. The results that you'll be discussing is something that we have to think about.
Yeah, exactly. So we know that Tenofovir is associated with bone loss in the adult population. There's still a lot of research that needs to be done with that. But people are concerned about exposing these babies to Tenofovir in utero because nobody really knows the long-term effects of these children in terms of their bone. So Dr. Siberi showed there were two groups. One was on Tenofovir at least 8 weeks in the third trimester, and the other group had no Tenofovir exposure at all. And they measured whole body total bone content in these children with DEXA scans. And he showed that those that were exposed to tenofovir had decreased total bone mineral content compared to those that weren't exposed. Now, this was a cross-sectional study, and we need more longitudinal studies to see if this has an impact for their long-term growth, their fracture risk, their BMD. But at this point, it is just something to be aware of as we treat more and more of these women with tenofovir.
I think
this wasn't presented at the conference, but it came up in the question and answer period to that talk, is that Gilead is developing a new agent that's a prodrug of tenofovir that reportedly has fewer of these types of side effects, but I don't believe we have that data in pediatric patients yet.
So she's referring to TAF that's currently in late stages in adult studies. It looks very promising. But it's going to be a few years before we can know if it's safe in pregnancy, if it's safe in infants, and what the implications are for that. But that is a potential option in the future if we show that tenofovir has issues with bone.
And I think these results weren't necessarily surprising. I think all of us in the field kind of always wondered about this. I think it was just a very well done study for us to kind of look at this further in the future and kind of confirm what all of our suspicions were.
Right. And this is, again, in utero exposure with HIV exposed uninfected infants. But there's still, in my opinion, a lot of concerns using tenofovir in younger children as they're still growing and developing their bone mass. And we'll see sort of as time goes on with regards to that. So that sort of brings up, if we start early, starting antiretroviral therapy, either in utero or in the HIV-infected children, especially if we're starting within hours of birth or even within the first 6 months, that there are a lot of implications for long-term exposure to antiretroviral therapy. And we're always looking in pediatrics to define what the best regimens are, and we're limited because there's not that many options that have been tested and confirmed dosage-wise and that are available in liquid or powder form. So there were a number of studies looking at the best ARVs in these infants and children and trying to determine if you could basically make their regimens less complex. And one of those studies was looking at lopinavir, ritonavir, once daily versus twice a day.
Right, yeah, that was a very interesting study. It was the final results of the CONCERT trial were presented. And I think just kind of as a background to the trial, lopinavir, ritonavir, the boosted protease inhibitor combination, is one of the staples in our armamentarium for pediatric patients. There are more and more drugs that are coming onto the market and more pediatric formulations, but for the time being, we've really relied on this agent. But it does have toxicities. It's typically given twice a day, and it has severe palatability issues in older children. So one of the idea behind this CONCERT trial was to study once daily lopinavir, ritonavir dosing compared to the standard twice daily. So it was a 1-to-1 randomization to this trial. And this was in treatment-experienced patients who were all less than 18 years of age. It was just under 200 patients. And they were randomized to the same drug, but once a day or twice a day. And they were followed for I think up to 50 weeks or 48 weeks. So it was a non-inferiority study, and they were actually not able to demonstrate non-inferiority of the once daily dosing. And that's based on viral loads that they found that were higher in that once daily treatment group.
So those of you who aren't familiar with non-inferiority studies, the goal is not to show that the once daily lopinavir, ritonavir is superior. The goal is just to show that it's non-inferior to the twice daily. And the benefit to the once daily lopinavir, ritonavir is that as PEDS ID physicians seeing HIV children, the biggest complaint we get is the taste and the GI upset that's associated with lopinavir ritonavir. It truly is horrific, and if any of you prescribe it and haven't tried it, you should try it because it is awful. It really is. So that's one of the reasons that they wanted to do this trial, I'm sure, is to see if they could get it down to once a day. Unfortunately, in this trial, they were not able to show non-inferiority. And this is, again, one trial, and I think it has to be done on an individual level because there, I think, are some implications with lopinavir ritonavir in terms of adherence. And one of the studies that I think really represents the issues with taking this medicine is the Never Rest 3 trial. And this, again, was a non-inferiority trial looking at, instead of having the exposed children on, for the HIV-infected children who normally would get lopinavir ritonavir, they randomized them to either stay on that or switch to efavirenz, which is another similar drug that we use as a mainstay in adults. We do use it in older children, but not so much in this case, and that was the point of the study, to see if keeping them on efavirenz was non-inferior to leaving them on lopinavir ritonavir. And that study did actually show non-inferiority, putting the children on efavirenz as opposed to leaving them on lopinavir ritonavir. But what I thought was very interesting, and you all can comment as well, the study was not designed to test this, and so the statistics, more anecdotal to me, was that one of the things that they looked at was non-suppression in the two groups, meaning at their end point, how many patients still had a viral load greater than 50. And it was 18% in the efavirenz group, but 28% in the lopinavir ritonavir arm. And when this was brought up, it's unclear, but some of this may be related to the non-compliance in the lopinavir ritonavir group, which really begs the question, does the taste really have an impact on whether people take this medicine or not?
Right.
In our personal experience, it certainly does.
And one of the things to point out with the Never Rest 3 trial is that I believe it was performed in children who had been exposed to nevirapine as part of PMTCT.
Right,
so there was a
Thank you.
concern
Yes,
about potential
right.
resistance to
Right,
the NNRTIs.
exactly. So they did not show the resistance. One thing that is important to point out is that the efavirenz group did have a number of adverse events, mostly related to sleep difficulties, which you'd expect given the CNS associated side effects with efavirenz. They showed 26% in the first 4 weeks. However, after the 4 weeks, it went down to less than 1%. So those side effects did go away, but it's, again, this balance of pros versus cons in treating these infants early.
Right. And in sort of the real world scenario, not a trial scenario, would those adverse effects, the sleep, insomnia or bad dreams, would those prevent patients from actually continuing the medication?
So there's the palatability and the side effects. One thing to add too is, even though the arm of efavirenz patients had higher viral load suppression, the lopinavir arm, I believe, actually had higher CD4 count at the end of the study compared to the efavirenz arm.
Right.
So just something to keep in mind.
Right.
And they did not test for resistance in that group, so I think
Right.
that was going to be their next step of looking at, like you said, these were all nevirapine-exposed children, looking to see, how these non-virally suppressed children on efavirenz did.
Right. So this just brings up a lot of the issues with antiretroviral therapy in these young infants. And going back to what we started with, starting antiretroviral therapy very early in these patients, even potentially, within a couple of days of life, there's a lot of limitations to that in the real world. Would either of you like to comment on some of the dosing issues with some of the commonly prescribed medicines when they're older, or with the preterm births and that sort of thing?
Well, I think we don't have a lot of data in terms of dosing or PK in pharmacokinetic data in the preterm infants. We do have good dosing guidelines for AZT and 3TC, and it seems like, at least what Ellen Chadwick talked about in her symposium talk today, it did seem as though we are going to have available data on nevirapine dosing for treatment
in the preterm.
Right. So that is really one of the difficulties, because everyone keeps talking about the Mississippi baby, but those doses were accidental doses, if you will. They weren't tested, and now we really have to do it as an evidence-based trial to see what those doses would be early on and what the implications are for long-term exposure.
And I think, just to kind of wrap it up, I think it's a balance of, we've seen based on these these reservoirs and the Mississippi baby, and even kind of the second baby that came up during this conference.
And you want to say a line or two about the
second baby?
Sure.
So the second baby is now, I think, 9 months of age. So the Mississippi baby was started around 30 hours of age, if I'm correct. And the second baby was started at 4 hours of age.
A high risk
baby. Very similar regimen, I think, of AZT, 3TC, nevirapine. And then at some point was on 4 drug, adding Kaletra. Eventually they stopped nevirapine and continued on AZT, 3TC, and Kaletra. And what they saw is, after, I think, 7 days, or 7 to 11 days, was complete viral suppression. Now this baby is 9 months of age, very similarly to this Mississippi baby, just, no proviral DNA that can be found. Is still on therapy, is still on triple therapy, but I think this is yet kind of other new evidence suggesting that starting early and being aggressive could be kind of the route that we have to take, but we should balance that with not knowing what doses to use, kind of the side effect, the exposures, etc.
And a similar topic too is, although the patients that were started early had better virologic control, there was no difference in the immune activation markers between those that were started later versus those that were started early. So I think that time will tell about the long-term complications associated with increased immune activation, and we just don't know some of those outcomes yet. So I wanted to thank you very much for joining us in the CROI updates, and we
stay tuned throughout the year.
Exactly. Thank you.
Thank you.
Thank you.